Tēnā tātou katoa. So I'd just like to thank Annette for the opportunity to be here today, and also to you guys for hanging on in there for the last presentation. I'm actually feeling quite nervous about standing up and speaking in front of such a specialised audience, because I myself don't have very much professional experience in the field of suicide prevention. But what I do come with is a long-standing, strong and active interest in mental health, which is what actually inspired me to put myself forward for taking on the responsibility of the work that I'll be sharing with you today. So what I'm hoping to be able to speak to you about is a literature review that I conducted in response to a request that was made by South Canterbury DHB. And that request was to examine the evidence base for school-based programmes that have been designed to prevent suicide and build resilience among students. Now, the original review contained a fair bit of South Canterbury specific content. However, since its general findings were considered to be of potential use to a wider audience than just South Canterbury DHB personnel, a more generic version was produced, and it's the findings of this particular document that I intend to speak to you about today. Now, since there isn't really time to speak to all of the issues that this review set out to address, I'm going to be restricting the focus of my talk to discussing the evidence for the effectiveness of key programmes, highlighting any moderators of and barriers to effectiveness, and discussing issues that may be of particular relevance to ethnic minority and Indigenous students. So, as the title of my talk suggests, two types of programme were included in the review. The first of these were classified as categorical programmes, and these are essentially programmes that use surveillance or instructional methods to specifically and explicitly address the problem of youth suicide. Now, because they have this specific and explicit focus on suicide, their delivery is typically restricted to secondary school settings. 5 types of categorical programme were identified, and I've listed these here on the left. Now, the second type of programme included were classified as social and emotional learning, or SEL programmes. The 7 SEL programmes included are listed here on the right. And all of these programmes can be conceptualised as having been designed to help students learn and master some of the individual level competencies that foster psychological resilience. And they each target children at specific stages of their school experience, with the target audience for this entire group of programmes ranging from the preschool to the secondary school years. Now, since I'm going to be talking about the evidence for the effectiveness of these programmes, I think it's really important that I highlight that very few studies have actually examined suicide completions or psychological resilience as outcomes. And this is essentially because these outcomes are quite difficult to measure. As Roger alluded to earlier, suicide is a statistically rare event, and psychological resilience is a fairly complex construct. I think it's therefore important to bear in mind that my conclusions regarding programme effectiveness are largely based on the assessments of proxy indicators, which may or may not have a clearly established association with either of the outcomes of interest. So with that said, if we start with the categorical programmes, the most promising programme to emerge from my analysis was Gatekeeper training for adults. Now, these types of training programme aim to enhance the identification and referral of students who may be at risk for suicide by improving the identification and intervention abilities of diverse adult members of the school community, including teachers, administrative staff, school health professionals and parents. Now, the evidence suggests that these types of programmes are effective in terms of improving knowledge, building confidence and increasing the use of recommended intervention behaviours among participants. However, 2 important moderators of programme effectiveness were identified. The first of these is the inclusion of role-play practice in standard training protocols, which has been found to encourage a more widespread use of recommended intervention behaviours among participants. And the second potential moderator is refresher update training. And essentially the need for this type of training was suggested by the finding that participants' gatekeeper skills tend to atrophy over time. Now, a number of potential barriers to effectiveness were also identified. Firstly, there's the potential for the under-identification of ethnic minority and Indigenous students. Another potential barrier is the lack of formal referral processes for non-school-based gatekeepers who may be part of the broader school community but who may themselves live and work outside of supportive institutional settings. And the remaining barriers include the potential for identified students to not access the services to which they've been referred, and the potential for these services to not be effective in terms of reducing youth suicide risk. Now, fortunately, the literature does suggest a number of ways in which these barriers might be overcome. The first is to ensure that the suicide risk indicators and warning signs communicated by Gatekeeper training programs are sensitive to the different ways in which distress may be expressed by different cultural groups. The second is to extend the offer of school-based Gatekeeper training to trusted and respected members of ethnic minority and Indigenous communities. The third is to institutionalise a referral link between non-school-based gatekeepers and school mental health professionals. And the final one is to ensure that school-based Gatekeeper training is delivered as part of a much broader district-wide suicide prevention programme that also addresses some of the known barriers to student help seeking and the regional provision of both effective and acceptable services. Now, as for the remaining categorical programmes, my analysis suggested that schools should refrain from implementing these programmes at the present time for a variety of different reasons. For suicide screening programmes, there are concerns about their effectiveness for ethnic minority students, largely because the vast majority of screening instruments have only been validated for white suburban students living in the US. There's also a lack of clarity about when and how often these instruments should be administered. And feasibility studies further suggest that the high rate of false positives typically generated by these programmes could place school personnel and local services under an unmanageable burden. And two further lines of evidence suggest that school-based suicide screening programs could meet with considerable resistance. Firstly, low levels of program acceptability have been reported among school professionals in the US. And secondly, a number of US-based studies report only modest student participation rates in screening programs, either because parents object to their child being screened or the students themselves refuse to be screened. And finally, there are unresolved concerns about the safety of these programs, with a recent Australian study suggesting that a substantial proportion of those students considered to be at risk for suicide may find the screening questions distressing. Now, for the remaining categorical programs, which include the curriculum-based programs, the peer helping programs, and the individual level school-based psychotherapeutic interventions, there are either concerns about safety or some unforeseen negative programmatic effects, or there was insufficient evidence to support their implementation at the present time. So if we move on to consider the social and emotional learning, or SEL programs, the most promising programs to emerge from my analysis were the grade level curriculum of promoting alternative thinking strategies, or paths, the Penn Resiliency Program, or PRP, the Friends for Life components of the broader Friends program, and the mindfulness-based programs. So I'm just going to discuss each of these programs in a little bit more detail, starting with the grade level curriculum of paths. Now, this is a primary school curriculum that's comprised of separate volumes of lessons for each of the relevant school years. It's therefore developmentally sequenced and fairly comprehensive. It has a strong focus on emotional development and is underpinned by a fairly robust theoretical framework. Although it was originally developed in the US, it's now been delivered in over 20 countries. Now, in terms of effectiveness, the evidence suggests that exposure to grade level paths can improve social emotional competence and neurocognitive functioning, reduce problem behaviour, and enhance classroom atmosphere. However, a number of important moderators of effectiveness were identified, with strong administrative support, skilled use of the curriculum by teachers, and less socially disadvantaged implementation contexts being associated with larger intervention effects. Now, another potential moderator of effectiveness is the extent of teacher training and support. And although this is yet to be formally assessed, the most robust findings were derived from US-based studies in which the teachers charged with implementation had received comprehensive training and ongoing support from PATHS project staff. And so for me, this really highlights the necessity for rigorous implementation if PATHS were to be imported to the New Zealand setting. Now, it makes sense to consider PRP and the Friends for Life curricula together, as these programs share a number of features in common. And these features include being based on traditional cognitive behavioural therapy models, having been developed by clinical psychologists, and having been designed to prevent the development of specific mental health symptoms. Now, in terms of their uniqueness, PRP is a US-based program that was designed to prevent depressive symptoms in children aged 10 to 14. In contrast, the child and youth versions of the Friends for Life curricula were developed in Australia with the intention of preventing anxiety symptoms in children aged 7 to 12 and 12 to 16 respectively. Now, in terms of the suitability of these programs for ethnic minority students, the work of the developers of PRP really stands out. And this is because they're keenly aware that some of the cognitive behavioural assumptions of PRP may not necessarily generate the most skillful practices for these participants. They've therefore been really careful not to impose European American standards and values upon them by developing a number of culturally tailored programme applications. Now, in terms of effectiveness, there's reasonably good evidence to suggest that PRP and some of its culturally tailored applications can reduce depressive symptoms, and that the Friends for Life curricula can reduce anxiety symptoms. There's also some but limited evidence to suggest that PRP may prevent the onset of depressive disorders, and that the Friends for Life curricula may prevent the onset of anxiety disorders. Now, despite these promising findings, some important moderators of programme effectiveness were identified. Essentially, overall intervention effects were modest, but tended to be larger when the programs were delivered to small groups of at-risk children, and when the people charged with implementation had either undergone clinical training or had received extensive training and support from the clinically trained program developers. And there was also some evidence to suggest the relative benefits of earlier rather than later intervention, with a couple of the Friends for Life studies reporting larger intervention effects for child versus youth participants. And finally, I think another point perhaps worth mentioning is that parent training components for each of these programs have been developed. And these components are really aimed at helping parents to reinforce the skills taught by the standard PRP and Friends for Life curricula. However, the research to date suggests that the inclusion of these components, at least in their current format, offers no additional benefit to students. Finally, the mindfulness-based programs represent a class of programs seeking to integrate social and emotional learning with mindfulness practice. Now, as far as school-based programs go, these programs are in the very early stages of research and development. Because of this, my review focused broadly on mindfulness-based programs for children and young people as a whole. Now, before I launch into discussing the evidence for the effectiveness of these programs, I think it's really important that I highlight that even these programs are in the relatively early stages of research and development. And because of this, there's still a need to determine what constitutes age-appropriate mindfulness practice for children at different stages of development, and also a need to determine how this practice might be adapted to ensure that it's safe for students experiencing high levels of distress and meaningful for students from diverse cultural backgrounds. Now, despite these precautionary words, preliminary findings suggest that participation in mindfulness-based programs may be associated with a range of benefits for children and young people, including reductions in stress, behaviour problems and mental health symptoms, and improvements in social-emotional competence and cognitive functioning. However, two potential moderators of effectiveness are already apparent. Firstly, a couple of studies have found that the improvements in individual well-being were positively related to the amount of mindfulness practice they undertook outside of the formal facilitated sessions. So this really suggests that individual student commitment to mindfulness practice will be a potent moderator of programme effectiveness. And another potential moderator is the extent of group leader training in mindfulness practice. And although this is yet to be formally assessed, the vast majority of studies evaluated the impact of programs that were facilitated by highly experienced mindfulness practitioners. So for me, this really leaves open the question of how effective these programs might be when delivered by teachers with considerably less experience in this area. So to summarise, my analysis of categorical programs suggests that the most promising school-based suicide prevention strategy would be to deliver Gatekeeper training to school personnel, parents, and members of local ethnic minority and Indigenous communities. And in terms of building resilience, my analysis of social and emotional learning programs suggested a number of potentially useful strategies. These include training teachers to deliver the grade-level paths curriculum to all primary school-age children, training clinicians to deliver the PRP or Friends for Life curricula to small groups of at-risk primary and or secondary school-age children, and contracting experienced mindfulness facilitators to offer culturally and developmentally appropriate mindfulness training to children of all school ages. Finally, I wish I had a little bit more time to say a few words about the wonderful contributions that each of these people made to this project. But since I haven't, I'm just going to say thank you to them as a group, and I'll leave you all with details of how to access the review. Thank you for your attention.